Live from New York, it's Thursday afternoon. Welcome to Benefit with Friends. I am your host, Lou Bernardi. We have a real exciting discussion today, topic, something that I talk about a lot, and unfortunately here in New York isn't something that's been growing very rapidly. Maybe we'll talk about that a little bit, but direct primary care. So direct primary care to me is something that can really, I guess to steal a phrase from Dave Chase, really can help restore the American dream. I've been involved in benefits for the last 30 plus years, and went along with the flow and saw how managed care really changed benefits from a health insurance side. And although it was there and really was happening underneath everybody's nose, managed care really significantly changed the whole landscape of how healthcare is delivered in this system. And direct primary care is definitely, I think, are a victim of that change in many ways. So my guest today, Dr. Jeffrey Gold, MD. Our topic is planting the seeds to rebuild a care system that works for the patient and the doctor. He, in 2014, after 8 years working for a major hospital system, opened up his first independent primary care practice in Massachusetts called Gold Direct Care PC. It's located in Salem, Massachusetts. So if you're in that area, definitely look him up. He currently cares for 700 or so patients as an internal medicine physician, and also started another business called Star Seed Group LLC, which is with the hopes of having DPC doctors, benefit advisors like myself, TPAs or third-party administrator, and self-funded employers collaborate with primary care being at the heart of their health insurance plan. So I want to bring Dr. Gold in right now. It worked. There he is. Dr. Gold, how are you?
I'm doing well, Lou. Thanks for having me. I appreciate it.
Awesome. Thank you for taking the time and joining me today. So I did a brief introduction of you. I know there's a lot more, and I'm going to tell you, don't hold back. We are not.
I don't think you have to worry.
In any way, so.
You get a New Yorker and a Bostonian here.
Yeah,
so,
exactly.
I don't think there's going to be much holding back.
We had to do this before, perhaps, I don't know if you're a hockey fan, but if the Rangers get far enough, I think their likely opponent in the round before the Stanley Cup would be Boston. Boston, right? So we'll see how that goes. So two great teams and perfect storm coming together, hopefully. But
I was there for the disgusting performance last night, where they really didn't show up for the first time this season. So had a good time with my daughter going.
Need more of that.
Game 2 was a little rough, so we're hoping to turn them around.
I didn't even realize. Did they lose last night?
Oh, they were awful. They lost 6-3. They were terrible.
Oh wow. Okay. Oh, good. There's hope.
Yeah.
So Rangers are getting hot at the right time, hopefully. So anyway, I just want, I'm assuming that maybe some people that are going to listen aren't even familiar with what direct primary care is, and as you know, even some doctors don't know what direct primary care is. So I'm going to let you explain to the audience what does that mean, direct primary care.
Sure. The only thing I wanted to correct you on in the intro is I'm actually a family physician. So I actually do, I treat newborn all the way up to geriatric. So I just wanted to clarify that, internal medicine, they only do 18 and up, but nevertheless, so I think, sometimes what I like to do is even start with the people even know what primary care is. I think it's been so devalued in our system that I don't even know if the public and employers really know the extent of what true primary care looks like, whether it's delivered by, a general pediatrician, a family physician, or an internal medicine doc. I think it's gotten to the point where, and this is no slight, to my colleagues that are currently toiling in the system, trying to do the best they can, is almost becoming what I call a referralist, where you have so little time to actually practice to the extent of your training that it's like you almost want people to ask for referrals because it's one less person that you have to see that day and document a 3-page note on. So I think, fortunately, the public, and I think it makes it even harder to sell direct primary care, which I'll get to what we do in a second, but I think in their mind, they're saying, okay, well, now we're going to do another fee or charge for that, for the wait that we had for 3 weeks to get seen, for 45-minute wait in the office for an 8-minute visit, to be referred out. We're going to pay extra for that. So I think, unfortunately, the public and employers don't even really know what primary care can do if it's allowed to operate the way that we trained to do it. Seeing 20 people a day in the fee-for-service model is not primary care. It's not care. And that's why I left. But what direct primary care is the best analogy I use for lay people is really the principle behind it is getting back to using health insurance the right way, and very similar to what we do with our car. We don't pay for gasoline and oil changes and maintenance and dings and fender benders with car insurance. We search around for the best quality, best cost, and we pay for it. And then, God forbid, if something catastrophic happens, we have a policy to protect us against financial ruin. And that's really what health insurance was supposed to be for. We've actually made health care very expensive by insuring all of it, instead of actually using insurance the right way. And you say don't hold back, so I won't hold back. I always say I'm not anti-insurance. I'm just anti-insurance for dumb shit. Is how I put it. So, if I can get a hemoglobin A1C blood test to screen someone for diabetes or monitor their diabetes treatment for $6, who benefits from that being billed through insurance and having a claim filed? And I think we all know the answers to who it benefits, but it doesn't benefit the doctor and it doesn't benefit the patient, for sure. So what we've decided in the direct primary care world, and I wish I could say that, I was the one that, came up with this concept, but I give all the credit to Erica Bliss and Garrison Bliss out in Seattle that started this whole movement back in 2009, is that, it's kind of like a combination of Netflix and Costco. You pay a monthly fee. We all do it differently, but pretty much all your primary care services, visits, telehealth, in-office procedures, communication with your doctor, everything is paid for like a gym membership or a Netflix membership, where, we can deliver care for an average of $75, $80 a month. And, pricing varies around the country, obviously, depending on cost of living. And,
Sure.
I do age-based pricing because obviously the older patients get, we expect that they're going to need more touch points, and, so they're a little more expensive than the kids under 21. But pretty much, it's there and there's no barrier to access. I always say insurance, if anything, often creates more barriers than needed. And we are insurance blind. We don't bill third parties, but I have people that are on Medicare. I have people with no insurance. I have people, on Cadillac health plans still that just want better access and better care and better relationship. I have people on huge deductibles that are tired of going in for one visit and getting billed $400 when that's, almost half a year of care to me. And then we're like Costco in the sense that by being a member here, we actually give people access to what things actually cost and try to break through these walls of, opacity and cause transparency, where, people think that A1C test is $105 because that's what the hospital bills insurance when it's $6.
Right.
So we pass those savings on to our patients so that, when they come in and they need a visit and maybe they need labs or they need an EKG, and, we can do all that for under $40,
Right.
on top of the membership with the EKG included. I'm just talking lab work, and get them care before something major happens where they're sitting at home, worried about, what's this going to cost?
Right.
So it's really that simple.
So,
I
let me just, I just want to, so for the listener out there, right? So what they need to understand is that this is a direct primary care doctor doesn't take insurance. You're paying a flat monthly membership fee,
Mhm.
right? And that will vary.
Yeah.
My daughter, who's on the other side of that door, who works for me, has the only direct primary care brick and mortar available here on Long Island. She's a patient for it because I got sick of 10 years or more of 4 to 10-minute appointments, most of which, and I look at it this way, like doctors, the typical, and I love doctors. I think, I don't, it's the system that we're in that makes doctors not be able to actually practice medicine the way that they've been, taught and where their passion is. But if this was a sport, doctors would have to have their names on their back, because you're looking at their back half the time, because the other burden, the administrative burden on so many doctors is that they have to put in notes and records and things like that. And if they waited till the end of the day, they'd have to work another 3 hours at the end of the day. So half the time they have their back to you, they're typing, the notes while you're there. You got to wonder, are they even listening? Or are they just putting the dots and crossing the T's to get to the next patient, right? Because of that fee for service, managed care. And, when you think about primary care doctors over the years, the health insurance systems or the health insurance companies have tried a lot of different ways of reimbursing primary care doctors, not for the advantage of the primary care doctor, right? Capitation, right? Referrals. Then there were no referrals. And then all the insurance companies changed their licenses and put it back on indemnity paperwork and sold EPO plans and PPO plans, right? And all of that was to benefit the insurance company and eliminate the barriers, so that maybe at one time they didn't want people to get as much treatment. They wanted to cause a situation where there was a speed bump, because and it's interesting. It was 2009. You kind of credit Dr. the Bliss for starting this type of transition just before the Affordable Care Act. But that changed the math, right? The Affordable Care Act, there's something called medical loss ratio, which means insurance companies now profit by paying more claims. So they eliminated the barriers, but they've still bombarded the primary care system of healthcare and made it so that to make a living, and you correct me if I'm wrong, because I'm not a doctor, but make a living, you have to see a lot of patients under the fee for service system. Doctors, especially at the primary care level, are not ridiculously compensated for their work, as probably a lot of people wouldn't understand that. They think doctors are making so much money, but the majority of the cost of healthcare, and where it's changed in the last 30 years since I got involved and managed care came in, is going to administrative costs and private equity. I think it's 70 cents on every dollar goes to administration, 30 cents goes to care, right? Yeah. So that is a pretty ridiculous number. When you're talking about direct primary care, that monthly fee that you're paying to be on, have access to that doctor, is 100% goes to that doctor. I mean, obviously, the doctor has a lot of expenses, which is probably
but a lot less. I mean, that's the thing. We could probably do 5 shows, because I can go on for hours here. But I think that's the biggest thing too. Is what people don't understand is that when you look at a hospital-owned primary care clinic, which is where I worked, those clinics on a good day operate at a loss. I mean, they're operating at like 65% overhead because of the administrative staff that needs to be there to support one doctor or nurse practitioner. But what people don't realize is the reason the system doesn't care about that loss is because for every employed doctor or nurse practitioner they have, that person generates about $2.3 million a year downstream in referrals and testing and where they send people. So they're fine with it. What we do is, because we don't have to deal with the third parties and the rule makers that do nothing as far as providing value, they just extract money, we're able to operate at about 45% overhead. I have an office of one office person and a medical assistant and a part-time nurse practitioner that I was able to hire last year. But everything is streamlined. We don't need 20 people pushing paper around, dealing with administrative waste, but that the rule makers impart. So, getting back to what you were saying about the value is, there's 2 points I want to make. Number one, primary care is very different than specialty care in most cases. And I'll give you an example. So what we do should be based on a relationship. Primary care, there's nothing sexy about it. There's nothing, we're not doing high-tech procedures, yada, yada, yada. It's about establishing a relationship of trust that you trust me as your physician to tell you what I know and also admit what I don't know. And if I don't know something, get you to the right person who does. But when you go to get that knee replaced, it's a transaction. Is it great if your surgeon, if he or she has a great bedside manner and is touchy-feely? It's great. But the reality is you want your knee fixed, you want to get off the table in one piece, and you hope you never see them again.
Right.
That's the reality. That's an insurable event. Ensuring a relationship with an I instead of an E is where we've gone wrong. So what ends up happening, and I'll give credit to one of my DPC colleagues in Lawrence, Kansas, Ryan Newhoffel. He came up from New Care. He came up with this great thought experiment that he posted on Facebook that I use all the time. He did this about 5 years ago. And I've asked many people this, is basically if I gave you $100 and I said, I want you to divvy it up into 2 pools, one for primary care and mental health and one for specialty and hospital care, how would you divvy it up? And there's no right or wrong answer. It all depends on your family history, your chronic conditions, whatever. But the reality is I have never had one patient or person that I've asked that question to put less than $20 towards primary care and mental health. Even if they're going through cancer treatment, they still would at least give $20 this way. So then I ask, if you look at the public and private payers in the US, how do they do it? How do they divide it? It's 7 cents on the dollar goes over here. And then we sit and we wonder why we have so many problems. We've basically put a city of all this ornate, beautiful stuff on a pair of stilts.
Right.
And said, let's see what happens. And then we wonder why the costs continue to go up. So the key is you can't build plans, in my opinion, and have a functioning system that works to protect everybody in the right way without a foundation that works and is solidified. And we have the total opposite. Yes.
Well, it's the foundation of health. Where does that come from? The misaligned incentives is a big, word these days in benefits, but that's really what we're eliminating any misaligned incentives. We're making sure that the doctor is compensated fairly for their time. Now, not only that, it's the amount of time you have, and I would assume that this is perhaps at the state level, the state insurance department level, maybe, that dictates the amount of patients a direct primary care doctor can have versus what a typical primary care doctor might have, right? So my first experience with my daughter when we signed up, Dr. Blyskill in Sayville, New York, wonderful doctor, reached out to her a couple of times. She's pretty busy, but because there's limited access, but it's still not a tremendous amount of awareness. But I went with my daughter for the first appointment, and it was an hour appointment. We got there and we walked into the office. There was nobody there. It was just a closed door. She came out. She was really, really friendly. Came out, signed my daughter, and she showed us around. She said, "Well, this is the waiting room, but it shouldn't be called that because no one waits.
Right.
We run on time.
Right.
You have 30-minute appointments. You have 45-minute. You have an hour appointments." Brought us in. Beautiful. I mean, I've never met a doctor that was under less stress than her, and was just wanted to spend time. Spent an entire hour with my daughter and myself. Part of the visit I was in there. I was just really kind of witnessing it, both as a dad who was so happy with the decision that we made, but then also as a benefit advisor, I'm seeing it up close and thinking, wow, this is what healthcare should have been. I remember, I'm a twin from Brooklyn, New York. Dr. Zimmerman was our doctor. He took care of the entire neighborhood. And then if you think about it, I'm 55. So 55 years ago, he's walking around Brooklyn, New York with his leather briefcase, house calls. He just knocked on the door. How you doing? Not because he was looking, he truly cared. He knew about every single one of his patients' health conditions. He knew
Well,
if he had a
it's
rash.
part of your community.
Yeah,
It's your community, and that's where primary care belongs. We need tertiary centers to treat the really bad stuff and the really rare stuff, but
yeah,
health starts in your community, and that's what we really want to try to get back to with direct primary care. Is we look at it like we're taking the oldest parts of medicine that do work and that
mhm,
have always worked, and we're taking the technology that we have now to enhance it and make it better.
right,
um, I don't want to talk to some random person on teledoc about my herpes.
right,
I don't. But I do, if I have a doctor that I have a relationship, which I do have a relationship with, he's not DPC, but if he went DPC, I would follow him
mhm,
because I trust him and I feel comfortable with him. And that's what everybody should have. And
absolutely.
and that's what we want to get back to, that kind of, it sounds corny, but it's that Marcus Welby, Norman Rock.
Oh, we just lost. He may have hit a button. I'm sure he'll be back in a second. We lost Dr. Gold there for a second. I think he ejected himself. It wasn't me. So I'll wait for him to jump back on. Hopefully, he didn't just lose internet. There he goes. All right. Oh, wait. There you go. I lost you for a second. You're
That's
back.
all right. Yeah, as I was saying, I think that, we just want to get back to that old school relationship based primary care where the reality is everybody talks about population health. And as you said, value based. Well, who's determining the value and who should determine the value?
Right.
Shouldn't the patient? If I'm not a good fit and I may not be, my personality, my style may not be good for everybody, and it's not.
Right.
And that's okay. Like,
I find that hard to believe.
you trust
Well,
me.
so you know what I try to, for me, it's informing I call them the American healthcare consumer, right? It's employers are consumers of really health insurance, but they really are consuming when you're buying insurance, an employer sponsored health insurance plan, whether it's fully insured or self-insured, you're actually buying access to healthcare for your employees in theory.
Mhm.
But they wrap it in a box, they put a bow on it, they call it insurance. So it's a lot easier to think about insurance. But if you go back 30 years ago, just before managed care, most plans sold in this country were indemnity plans. There were no networks, there weren't books to thumb through. Doctors were mostly independent. I mean, there were practices and there were
Yeah.
partnerships, things like that, but they weren't part of the healthcare systems, the hospital systems. That started much more recently. And what happened was, just to quickly go through it in my mind, right, as a benefit broker, and I never thought about this as it was happening. You would think, oh, this is awesome. Northwell, NYU, these systems are growing. They're going to use that growth and size to the benefit of their patients, right? That's what you would think. Just like insurance companies growing, you think they're using their leverage, they're using their patient base or their member base to get best prices. But that's not the case. But hospitals needed to come together because the insurance companies' discounts, which at a time were actual, were beating the hospitals up. They were accepting, I don't know, 60 cents on the dollar. Their investors weren't happy. They got together and said, "We need to do something about this. These managed care companies are killing us. So let's join together. So it'll be a little bit harder for them to negotiate. We'll have some leverage." So they did that, and they were really successful. I think the largest hospital system in the country has like 140 hospitals under one umbrella. But they didn't stop there. And then they started merging vertically into the facilities, into the specialties, the radiologists, the labs, the urgent cares,
Mhm.
all the way down to the primary care doctors, which were really hurting. I had he's actually just since retired, but he was a specialist actually. He wasn't a primary care doctor, but probably the best doctor that I've ever been to personally under the managed care system. And he would spend 45 minutes just talking to you. And he was a specialist. He was a gastroenterologist, but he would talk to me about my weight all the time and dieting. He was passionate about the people. And I would talk, I really wanted to have him on the show, but COVID happened and I didn't see him for a year or two. And I went back to see him and it said the hospital system on his building. And I was really disappointed. I was like, oh man, they got to him too. And I
Yeah.
asked him about it. And he said, Lou, I hadn't gotten a nickel more out of insurance in the past 10 years. My fees, in order to make more money, I had to sign with the hospital system. So just having that logo on his building immediately got him higher fees. It shouldn't. It should be the quality of the care. It should be that people are going to see him and he's being compensated because he's such a great doctor and cares about people. And when you go to see a doctor like that, you know you're taking care of your health.
Right.
You're not just there to make the doctor money. Doctors should be able to perform and be compensated by the quality of their work, not the quantity of their work. Right? You just if you had to see 100 patients a day,
yep,
there's no way that the quality of your work could be at the same standards that you perform to today.
Mm-hmm.
Have you so you were in the private practice, you were in the the traditional primary care for 8 years. How did you make that transition? Because that's a hard transition for a doctor to make, and I wanted to talk about that today. The barrier to entry for doctors. You can't just wake up one day and say, I wanted to be a direct primary care doctor, because that cash flow or the claims flow stops. Now it's just, I have to have a body of patients. How were you able to do that? How difficult was that?
Yeah, it was brutal.
Did you lose any sleep?
Yeah,
making that decision?
all this,
Yeah.
Divorce. I mean, a whole bunch of stuff.
Wow.
I mean, I think that people, as you mentioned earlier, think that a lot of doctors are just, riding high on the hog here and golfing every Wednesday. And, and maybe that was the vision of, when I was a kid growing up. But the reality is, you're graduating with a lot of debt. We're giving up pretty much most of the 20s to pay to go to school and train and work to try to do the right thing. And you have this idealistic vision of what you want to do. And it's definitely a topic for another day, but the way you're educated is part and parcel of the problem. And, and it took me a while to figure that out. But, I had people that knew that I was miserable. They knew I was unhappy and depressed, and, were like, why don't you do concierge? And I was like, well, I don't begrudge anybody doing it, but you're still billing third parties. You're charging people minimum $1,500 a year that not everybody can afford. And it just didn't fit with, what I wanted. And I knew nothing about DPC or direct primary care. And then when in my ADD rattled brain, I was for years trying to figure out, like, what is the way that we fix this? And I just, couldn't do it. And then when I heard about DPC, it was like a light bulb went off, and I was like, this is it. And I was like, this is what people are already doing, and this actually makes sense. And someone's already formulated what my brain, wasn't capable of doing. And then the minute I read about it, I was like, this is it. I got to do this. And I actually, traveled to Atlas MD in Wichita, Kansas, and shadowed them for a few days. I started reading more and more about the ACA and health policy in general. And I actually put together a presentation to my old hospital employer to see if they wanted to pilot it with me there, give me 400 or 500 patients, and they could do a study or, look at outcomes, whatever they wanted to do. And I mean, I knew it would go nowhere, but, I thought it was the right thing to do. And they said to me, if we can't do this with you, are you still planning on staying in the area as part of the system? And I said, yeah, the specialist relationships I have, the hospital, I don't want to lose any of that. And it was nothing personal. I just couldn't practice in that model anymore. So my ex-wife and I, we had applied, to get a loan to a bank, and I was going to go hang a little shingle somewhere with as you described, small little private office and do my thing. I mean, we don't have any, there's no non-compete here in Mass, but I couldn't market, obviously, to the patients I had, because message alert to patients, you are not property of the doctor. You are property of the hospital that owns the doctor.
Wow.
So I had to be very careful of, how I did things. But one of my patients, who I've been with for a while, uses a concierge doc down in Naples, Florida, when he's down there for the winter, and then was seeing me up when he's back up here for the summer. And he, did very well in the stop loss world, and he understood kind of how the system works and doesn't. And he said, "Why don't you do concierge?" And I said, "Well, it's just not my thing." And I said, "Have you heard of DPC?" And he said, "No." So he was going to Florida. He said, "Send me a bunch of stuff to read." He said, "Don't sign a bank loan until you talk to me first." And he came back. That was April 14. He came back, sat my ex-wife and I down and said, "Do you guys want a line of credit, simple interest, pay me, 75% of the annual profit until you pay me back, build my salary into the loan." And I was like, how can I not? I had my old family attorney, rest in peace, look at it at a Panera. I'll never forget. He looked at the 1-page loan note and he said, "Jeff, if I try to get this for a client, they'd laugh at me." He's like, "This is the closest thing you're going to get to a gift." So he said, "This guy obviously has faith in you. He obviously believes in what you're trying to do and wants to help you." He's like, "Do it." So, we probably spend more money to start up than, than we really had to. I mean, but he wanted, brand new equipment and, top of the line stuff. He's like, "If you're going to do this, you're going to do it the right way." And, and I don't regret doing that. I mean, of course, I'm still in debt, and I'm very open about my situation because I know that not everyone is going to have an angel investor that they can go to and have a situation where they don't have to worry about keeping their lights on if they have a month where only 2 people sign up. But I'll tell you, getting back to the question, I mean, I really fooled myself. I mean, I thought that, as I always say, I was everybody's favorite doctor until I didn't take their insurance. And, you realize, and I've written about this, in blog posts and stuff, that I've framed it in the addiction model. I mean, I think the worst addiction we have in this country is to health insurance, as a form of payment for everything. And I thought I would have, lines down the street, given how bad the system is, of people wanting to sign up. And it just didn't work that way. I mean, I think out of the 3,000 patients I had, which is pretty typical, for an insurance-based primary care doctor, right off the bat, after 12 years, I think only 110 came with me.
Wow.
More came as time went on, and it was good. I got new patients and new blood in there, but it's not for the faint of heart, and it's very regional. It depends on where you are. Certain state laws make certain things very complicated. New York is a state that is very similar to Massachusetts. It is not easy to do things innovative in healthcare without over regulation. Places like Kansas that didn't expand Medicaid, DPC was like a saving safety net, for a lot of people that made too much money to qualify for subsidies, but ran their own business and didn't make enough that they could spend $600 a month on a $3,000 deductible health plan.
Right.
Massachusetts is different. So it took a lot, and it's still to this day, it's just constant working on getting people sober. And the hard part is when you look at anybody who struggles with addiction, as we do every day, doing what we do, they want to get better. I mean, people who smoke cigarettes, they know it's not good for them. They're not dummies. They know that. But the question is do they want to go through the pain of change?
Right.
And it's hard for doctors. It's hard for patients. It's hard for employers. It's hard for everybody because this is the way things have been done for so long. I mean, we have people that think they're doing something illegal.
Yeah.
Almost,
Right.
it's like, no, it's not illegal to pay a doctor directly.
Right.
Like, no, nor should it be.
Well, it's like that set it and forget it, right, mentality. And it's, when you make the assumptions that most people do about your insurance companies and the healthcare system, it's easy to think you're in good hands, right? I'm getting the best prices. I'm getting the best. How could you get better prices than this? And I tell people all the time, I couldn't get better prices if that was their intention.
Right.
Their intention is not to drive down cost. The intention of hospital systems is not to provide the best care at an affordable rate. They answer to Wall Street. They answer to investors, a board of directors. The real tough decisions, the masterminds that are continuously changing the rules of the game are in boardrooms that no one knows who they are, right? Those are the decisions. It's how much money can we suck out of the American healthcare system, and they don't care who the casualties are. They don't care that the primary care doctors are struggling. It doesn't matter that people that are walking around, I posted something recently. The top 4 insurers in the country had $11 billion in profit in the third quarter of 2022.
Right after a pandemic.
Do you think anybody's premiums went down? No.
No,
They invented medical trend. People think when, one of the things, I'll talk about insurance a little bit here now for a second, but medical trend, it's just a word, right? It's on your renewal. No one knows what it is. People think that medical trend is that the cost of healthcare goes up by 10% every year, and that's because doctors' prices are increasing because they think healthcare, they think the practitioner. It's not. The insurance companies are happily paying 10% more potentially, but it's not going to the practitioner. It's going to the facilities. It's going to those kind of silent partners. Healthcare and health insurance both want your costs to go up. They don't want the individual providers to get richer. They want their systems to get richer. They want their investors to get richer. And they don't care that the consequences that, when the indemnity plans were starting to be replaced by managed care, our average deductible at the time was about $250. And they had introduced co-insurance. There was a time when, and people on the call may not remember, but I certainly do, you had 100% coverage, 100%. And the single rate was $54 for like a 30-year-old male, right, here in New York. How is that possible, right? They didn't go to the doctor. They weren't steering people into the system to get the highest price. And that's one of the other things. So you kind of alluded to it before, is that, hospital systems that employ doctors will happily lose money on running that practice, but they're making up for it 10 times as a result of the steerage, because now that doctor doesn't have their say. They have to meet their quotas. It's like the 31st of the month, the police are out there because they just got, they got blasted because they didn't write enough tickets that month. Guess what? Now you're getting a ticket if we're going 2 miles an hour over, because they have to make that. They have to write those tickets. As a doctor, you have to see X number of patients a day. You have 15 minutes for lunch. You're responsible for doing the notes. So figure out how you're going to do that. And by the way, X%, I'm going to make an assumption here. I don't know if it's a percentage. Would you say that the referrals for things like MRIs, CAT scans, sonos are based on a quota they have to meet, or just that if someone really needs it, make sure you refer them into our facilities that are affiliated with the hospital systems, where it's going to be billed at $5,000 and paid at $2,500? Are they actually sending people for tests that they know aren't necessary simply because they know the insurance company will approve it if we put a certain diagnosis down?
Yeah, I think it's multifactorial. I think that's definitely part of it. I think the other part of it is you're really covering your own ass, because when you're seeing 20 people a day, you don't want to miss anything. So you're much more likely to err on the side of caution. And especially when you're in a model where, you have no concept of what things cost and don't cost, or what they cost where, you're more likely to just reflexively order it. And I mean, you never get a document saying that this is what you have to do, but it's kind of like getting back to hockey, the informal rules, the informal rule book. There's just rules. You don't keep beating a guy when his head's down on the ice. There's informal rules where you just know that you're not referring out to a different hospital system to see that specialist or MRI, because you probably will, if you frequently do it, hear about it.
Absolutely.
I mean, if people only knew, I mean, there are so many horror stories that I'm sitting on up in here of what meetings we were told to do as far as coding, fucking with medical records, vital signs to get your pay for performance contracts met, as the group, and then we're going to give you a bonus, which is really a withhold return, which is money you should have been paid anyway. It's really sad. And what I tell people is just the key question you have to ask yourself is, who do you want your doctor working for?
Right.
Plain
Yeah, absolutely. You want them working for the patient, right? And so to connect this with the insurance, right? Because you mentioned it kind of when we first went on, is why would someone want to pay $75 for a primary care doctor when they're already paying too much for insurance? And what you have to think, if you're a plan sponsor, if you're a CEO, CFO, HR director out there, what we're really suggesting potentially, right? So there, and this can go many different directions, but let's just assume you're fully insured today. And so many employers now are holding on to gold plans, right? Paying a lot of money for gold plans because they're thinking about the insurance, they're thinking about potentially the out-of-pocket cost. But now they're making the cost of the program to the employer and to the members very expensive. You take that gold plan and you switch it to a silver or a bronze plan. And then you offer direct primary care as an option where the employer could pay for it for their employees. And no cost for the direct primary care doctor whatsoever. You've eliminated any barriers to care. That doctor, and I would assume, and I don't know, maybe there is a number, but I would assume primary care doctors, when allowed to do what they're capable of doing, right? Because the other thing about the healthcare systems is you can't do it there. You can't do an X-ray in your office if you're part of XYZ managed care company, right? But depending on your state and your equipment and your facility, could primary care doctors take care of 80% of why people even go to the doctor? Is it more than that?
Easily,
right? So now you're not paying for that more expensive specialty care.
Right.
Okay? So now you offer a plan, you take the premium savings between the gold and the silver or the gold and the bronze, make it an option for employees. You have a 200-person company and you say, here's plan one, because not everybody's ready to take that jump. But you have people that don't even go to the doctor.
Most people at this point, when you look at statistics, about 50% of people have no relationship with a primary care doctor. They're using doc in the boxes, is what I call them. And you're lucky if you do get a doctor there. And then most of them, if they do have a primary care doctor, don't even know what that doctor looks like, and vice versa.
You can't get into the doctor when you really need them.
Right.
That's the other problem. So now you have this direct primary care option with an underlying. We're not talking about eliminating a health insurance plan, right? You need something there for catastrophic situation, right? Most people would say, okay, well, when was the last time I was in the hospital? Was the day I was born. Knock on wood. Some people go 3 times a year. It does happen. So you have this underlying health insurance plan. You have a much more comprehensive primary care, which is going to help the employer eliminate a lot of the unnecessary claim spend, upcoding, all of these coding errors, all of the manipulations. There are so many things that happen when you're dealing with insurance companies because it's business, right? There's a lot of inappropriate billing, incorrect billing. It's very complex. You're not sending a bill to the insurance company. You have your doors open, and there can also be, and I'm assuming that maybe your practice works this way, options for it to be virtual or an email or just a quick phone call, right? It's not like someone has to come. I think it's unbelievable that they can come and you have a brick and mortar, facility, but you're there to take care of the people and meet them. Maybe they don't have to miss a day's work or wait 3 weeks. And now they have pneumonia when it was maybe just, a bad cold when it started. There's so many different things. So, under a fully insured model, it can really definitely help because today there's so many people that are walking around with high deductible health plans, HSA plans that avoid care completely. I have a stat here. 38% of employees with insurance admit to avoiding or delaying care because of their out-of-pocket cost. That's unacceptable. 38%, more than 1 out of every 3 people with insurance isn't getting the care. So what service is your insurance providing you? When that's the barrier, is the insurance, is that upfront out-of-pocket cost. But then you talked about, and I had to close the other window, this other thing that you've started, this other program, which is hoping to bring direct primary care, TPAs, stop loss companies, advisors, and employers together. If you could talk about like what that vision is that you have there.
Yeah, well, my vision is, kind of what you touched on with this vertical integration, and then which we know doesn't work. And then you look at the independent docs that remain left, whether a specialist or primary care, that tried to do a horizontal integration where they form these, independent physician groups to try to negotiate, better price, which, didn't work either because they didn't have the clout and the power to negotiate for better, reimbursements. I mean, that's how doctors get paid, is getting reimbursed.
Right.
So one morning, one night, I had this literally vision where I just kind of woke up in the middle of the night and I was like, well, shouldn't healthcare be a wheel? And, I wrote it down on, and I've never done this. I just wrote it down on like a little piece of paper and a napkin or something. And then, at the time I have 13-year-old twins, boy and a girl, and my daughter was probably like 9 at the time. And she helped me put it into a graphic on the computer because I'm useless with that stuff. But basically it's, you wouldn't write laws without lawyers, but yet here we are writing health plans without doctors, right?
Yeah.
I'm not an insurance guy. I don't want to be an insurance guy, but I want to collaborate with it. I don't want to work for an insurance company, but I'd work with them because insurance is a key component of protecting people
Sure.
in healthcare. But yet, how do you design a plan this way or this way and expect it to work? You've got to have primary care, and I include mental health as at the hub,
Mm-hmm.
and then everything else is a spoke and an extension, and you have your stop loss around it. I mean, I have the diagram. I won't show it, but for people who are interested in like sitting down and working together, I mean, that's what my hope is that we can take that diagram and customize it with all those key pieces, the TPA, the PBM, the stop loss, all the things that are crucial to making that wheel in that ecosystem work the right way for the client that you're dealing with.
Mm-hmm.
How you work with a group of construction guys is going to be very different than what you need for yoga studios. They're different needs, and that's okay. But if you have to have those core elements, you have to have, and really, to me, it's got to be DPC at the middle. I mean, I admit I'm biased. It's what I do. But to me, if your plan is centered around employees using primary care from a hospital-based primary care doctor, and this has nothing to do with the doctor. And I actually just wrote an article last week that I got a lot of flack for from colleagues because you can go read it. It's called Aiding and Abetting. I posted it last week on LinkedIn. But you've got to have that independent direct pay where you're investing in that relationship and that downstream ROI, and then direct contracting on imaging, and using things like green imaging and, Medmo and like all these other people out there that are even surgeries, just finding the best quality, lowest cost. Cash is king, and it always will be. And if you extract, as Carl Schuessler always say, get rid of the middles.
Yeah.
If you get rid of as many middles as possible, but you're doing it in a collaborative way, like I've learned so much, from going to these conferences. And if you asked me 15 years ago if I'd be going to health insurance conferences, I'd laugh at you. But the reality is it's long overdue. We have to start working together because your daughter, my kids, their future kids, if we don't fix this mess that we've all been part of creating in some way,
Yeah.
it's going to be pretty bad.
Oh, it's already so bad, but it's all indications are it's just going to get worse.
Right.
I always use in my mind the visual of this net,
Yeah.
right? So the healthcare system is casting a net. They're using their primary care doctors that work for the health systems to make sure as little escapes the net as possible. Everything is being upsold into our healthcare system, right? The healthcare system might own an independent radiology facility, but they want you to go to the one here that's affiliated with the hospital because they can charge or get paid. The charge is irrelevant, but they're going to get paid 4 times more here. It doesn't matter if the patient has an insurance plan with a $10,000 family deductible. There's no one there to help say, well, did you know you can go to this one? If you pay cash, you can get it for $500. I can
Right.
get you in today. I have a relationship with this facility. The doctor can't do that, right? You have all these gag orders, which I guess recently have been eliminated, but that net is really what's driving up so much of the claim cost. And then you have the health insurance companies that are casting a net, and they just want as many members as possible, right? They just want to get all the members. Now they're becoming the providers. Insurance companies, I think United Healthcare is the #1 employer of doctors in the country.
Mm-hmm.
So they're the insurance, they're also the provider.
Yep.
They build plans that incentivize members by lowering the upfront out-of-pocket cost to go to those insurance carrier-owned facilities, and then they pay themselves not less, they pay themselves more, right? So they're
Right.
not doing it for the sake of let's drive down healthcare costs. It's everything is about let's drive up premiums, let's drive up claims, let's drive up profits. So now I'm thinking if an employer who's spending all this money, or maybe the employee, it's a cost share between employees and employers. Once they understand that it's a very ugly business, but it is business, why don't I throw a net out and say, I can get all of these claims, 80% of my claims could have been cared for at a primary care doctor setting where there's no misalignment, no reason for that provider to upsell anything, right? And then I can even, provide through the TPA. Let's just talk about self-insurance for a second. If you're self-insuring and you have that direct primary care model at the hub,
Mhm.
and this is a fixed cost, this is a predictable cost. I'm paying 50, 75, 80, $100, whatever it is per month per member. I know what that cost is. And I'm now going to eliminate not only the other additional unnecessary specialty care, things like that, but think about all of the medications that are prescribed by providers that also have misaligned incentives.
Right.
Injectable medications, specialty medications, which are a real big problem already. And there's just more every year that are going to be entering the market. These are medications that are $10,000, $20,000, $30,000 per month that might be, in some cases, 10% effective.
Right.
Right? Wouldn't want a doctor that knows your insurance and says, well, maybe we could try this, but has that relation, looks at that patient as a person, as a whole person, and understands the stress that unnecessary and costly healthcare could have on their family. I mean, it's just really, 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 insane what's happening. And, I think employers need to start looking at their insurance and understanding this is a huge business decision. And if we don't get off of this mouse wheel we're on, it's never going to stop. You can't control the cost of your insurance when that's your main focus in insurance. We're telling people all the time, my job is to take the focus off of insurance and put it on the cost and quality of healthcare. How is your plan serving the needs of your employees and their families? When you do that, I haven't found a situation where you actually don't end up saving money. But it's not the goal to save money. The goal is to provide the best care for your employees. And I think for me, I'm very passionate about primary care. I mean, when I found out about direct primary care the first time, I went right on that mapper, DPC mapper, Frontier, whatever. And I was like, there aren't any here. I'm on the Forbes Business Council, and I was on a call a few months ago, and I'm in this finance group because I'm insurance, so it's kind of like finance. So they throw me in this group, and I'm on a call, and everybody's introducing themselves and what they do, and everybody's in banking and finance and investments and all these things. And I'm like, oh, this is going to be embarrassing. I'm a health insurance advisor. Right? People call me Boo because I'm the benefit optimization officer. I stopped the meeting in its tracks because what I wasn't expecting is they all wanted to know. They asked me, can you tell us what direct primary care is? Because they see such a shift in private equity money going into that arena.
Yeah,
That
they're
to
not
me was like,
stupid.
wow. If
They're
you
not
follow the
stupid.
money, right, you're going
Yeah.
to know what healthcare is going to look like in 5 to 10 years. Right. So I don't know what your thoughts. I thought about that. I'm like, I don't know. Do I want private equity being
No,
involved in that relationship again?
no, because then you're just look, and I mean, I don't blame them. I don't blame urgent cares for popping up all over the place because
Sure.
it's a great business model for a fractured system that doesn't work. Why
Right.
who wouldn't take an opportunity? And I'm not going to sit here and say that, I hope someday I can get my investor paid off and make money too. I mean,
Yeah.
I'm a capitalist through and through, but the question is what would I do with that money? Do I need a yacht? No. Do I want a yacht? No. Do I hope that I can maybe have enough money someday to open up a DPC clinic like this that serves people that really truly can't afford it? Yes. Profit's not a bad thing. It's what you do with it.
Absolutely.
And, I really feel that there's a lot of, and even in DPC, there's bad seeds too. I mean, just like with anything, and people get pretty quick at sniffing them out,
Yeah.
but my answer to that is no, is I think I really think, and that's why, if you look up what a star seed is, you'll see it's kind of out there, and I'm a little out there too. I probably got hit in the head too many times, but it's literally planting seeds and really nurturing this organically so that it really has a root foothold in how
Right.
we fix this. Bringing in more money people is not going to fix this.
Right.
Everybody wants to build the new best tech platform and chat GPT and all that stuff. And it's not that stuff can't help, but no one has invested in what the real way to fix healthcare is, which is the patient-physician relationship.
Yeah. One of the things I think about, and we're coming up on the hour, and I know you probably have to go, but
No, I'm a DPC doc. I don't have 20 people.
I was waiting for that. I was like, I don't know. But and what was I just going to say? Shoot. Oh boy. Oh, I just lost my. Oh, so when my children were going to school, we found out about these programs for STEM programs here in New York, and I'm sure it's not the only state that does this, but New York State, if you go to a state university for science, technology, engineering, or math, and you graduate, they will pay your student loans as long as you agree to stay in the state for 5 years.
Mhm.
Does something like that exist for providers? I'm thinking if you go into direct primary care and you come out of medical school as a pathway to do this. I mean, I'm just trying to find ways where this can happen. Help that provider, pay off those really huge loans because who's serving their community more than, I mean, science, technology, engineering, math, those are great. My son's a aerospace engineer. He works for Blue Origin now. I'll shout out to Andrew out in Washington State. But man, can't you find a pathway to help doctors with that financial barrier? There should not be this huge financial barrier for medical providers to get into something that's going to be just so impactful to those communities they serve.
Yeah. I mean, well, I went to UMass Med School, which was built in the late 60s, early 70s to bring more primary care docs to Mass. And one of the things they had at the time, or I think they still have, is the learning contract, where if you end up doing a primary care residency in the state, or if you go out of state for residency, but come back and do 5 years of work in a primary care field in Massachusetts, the 2/3 of tuition that were deferred when you were there, you don't have to pay back.
Wow.
So there are programs out there that exist, but the reality is you still have to make it appealing to do that career. And
Right.
right now, who the hell would want to do, insurance-based primary care?
Right.
Like that's the reality. So, we do have a chicken or the egg problem. And this is where I lean on people like you in your industry is, as you said earlier, when we come out of residency, we have no business training, and you sign those employment contracts and those insurance contracts, and you're guaranteed, because of this addiction we have, you're guaranteed patients, and you will get paid and you will get busy very quick.
Right.
Going into DPC, and there's people, colleagues of mine and friends of mine, that have done it right out of residency that have way bigger cojones than I do, because I don't know if I would have done it right out of residency, but they've done it, and they've done it well, and they've been successful. But the best way that I can help my colleagues, and this is what the hope of like a Starseed type plan is to bring employer groups that want this. So that I can go to my colleagues and I can say, look, that barrier that you have about your mortgage and your loans, well, I've got 400 lives waiting for you to take care of. Until we can do that, it is going to be it's scaling left and right. I mean, it's growing every day.
Yeah.
To get to that, if you ever read anything by Malcolm Gladwell, to get to that tipping point where finally, like, this is the norm, which is what we want. I want every American to have this.
Yeah.
Plain and simple.
But until we get to
that point where I can go to a colleague or I can go to a resident and say, look, I can guarantee you a $250,000 salary and benefits right off the bat, and just let you take care of these people and do the job that you trained to do, and I'm here to support you. It's just going to be that organic grind, which isn't a bad thing, but that's where employers will say, well, there's not enough of you. Okay, well, there's the problem. How do we get enough of us?
Right.
Give me lives to take care of.
Right.
Well, then what about, we have employees all over. Okay, well, you can drive from Maine to Alaska now and have a DPC doc in almost every state. So yes, there may be some areas that are DPC barren, but maybe we do a telehealth option. There's ways around this. It's just pick your heart is what it boils down to. And
it comes down to awareness, I mean, and I'm connecting you with, I won't mention his name, but one of my clients who has 8 locations in Brooklyn. He has, about 100 employees working for him. He was only vaguely familiar with what direct primary care is, and he's a pretty successful, I think, primary care quasi specialty provider. Yeah. So, I'm definitely, after we get off this call, I will try to reignite that connection. So, I just want to thank you. This is great. Anything else you wanted to add before we kind of come to
No, I just want to say, if you're, a benefits advisor, you're an employer, you're a doctor, you're a patient, I'm always happy to talk. I just reach out. Because the reality is this affects all of us. And if it hasn't affected you yet, it will someday. I mean, we're all patients, we're all humans, and, it's going to take a village. It's not going to take just, one Lou and one Jeff to do this. It's going to take a village of people. And, I think as long as we all have the same incentive, and like I said, making money is not a bad thing, but it's how you go about doing it and what the value you're providing is that matters, and what you're going to do with that money. This is our future, plain and simple.
Well, Jeffrey S. Gold, MD, you can definitely find him on LinkedIn. Always we met at those conferences, so I know your passion is there, and it's a tough fight, but keep fighting it, and we're doing it on our end. And I'm just as blown away as you are that we're even on this call together, because 10 years ago I didn't even connect. I knew I was selling insurance, but I was selling insurance. Didn't think about what was happening on the healthcare side of it, and how those products we were selling, may or may not have been serving their people. So thank you so much. I appreciate your time, and so relaxed for a doctor.
Thanks for having me on, Lou. Awesome. And I can honestly say too that the other benefit of doing this type of stuff is you actually do get to meet people outside of your own little circle that you become friends with, and you realize you really are on the same mission. You're just coming at it from different ways. And I've met some amazing people that if I stayed at my old job, I never would have met. So thanks for having me on, and I really appreciate it, Lou.
Yeah, well, we're attacking it from different angles. That's the best way to solve a problem, right? So thank you so much. I will talk to you soon, and appreciate you being on the show today.
All right. Thanks.
Thank you. Take care.